All right, so some of this is just going to be a basic refresher, obviously. We're going to hit the numbers, we're going to talk about stuff. When I give you points to think about it's also going to be on a test. So it's not just practical for use in the field, but it's also for the testing. Okay, so O2 tanks. What's considered a full O2 tank? You go and you check it and you say, all right, well, this has got this much PSI, so it's considered full. 2,000 or higher. 2,000 or higher, it's considered full. All right, at what point would you say to yourself, okay, this thing's too low, we can use it on this call, but after this call, we got to put it out? 500, if it's at 500. Then what is it if you look at it and you're like, oh, that's too low, we can't even use this?
Under 500.
It is going to be under 500, that's not a wrong answer. 200. 200 or less is considered out of service at that point, okay? So, knowing that, just a quick refresher on how to set up your O2 tank. One thing that's unique about O2 in particular is what? It has two prongs here, right? You know that O2 bottles are the only bottles that have this, so that you don't put the wrong regulator on it. When you go to put a regulator on it, what should you look for in here?
Gasket.
In both of those, right? We also call it the O-ring, it's a gasket, all those things need to be there. Because if it's not in there, what's going to happen? It's going to leak. As soon as you turn it on, it's going to be blowing out air everywhere, right? So you slip that on, make sure those two little prongs are seated, which I can't see, there we go. And then you just tighten that up. Now look, if you're coming on after A shift, there's always that one dude on A shift that, I'm not picking on you, Ronald, this is probably not you. This is one of the other people on your shift. They like to take this and then show they're strong. And look, a man the size of Donovan cranking on this bad boy, you are screwed. You are not getting this off. It doesn't take Operation Crankville, right? So you just snug. I tell you, I can't tell you how many times I come in. A shift just on the next day. And I'm like, oh my God, what are they doing? I'm gonna get a wrench and hammer on it. So don't do that, don't crank it down, all right? Once you get that snugged on there, you simply take and you're gonna turn it on. Now this is probably gonna leak because this, it didn't leak good. This regulator yesterday is giving me a hard time. When you turn it on, turn it all the way on, then a half turn back. Why do you do that? What's the point of the half turn back? I like the fact that your eyebrows did a little bit of a V action. That tells me that you never even heard that probably. So why do you think you should do a full turn on and then a half turn back?
Clean the dust off near the top of the ring.
So you're right, you should do that before you put the gasket on, right? So you take the thing off, you crank it and blow the dust out. That's what you do before you put the regulator on. Once the regulator's on, you want to turn it all the way on. First reason why you turn it all the way on is because if you turn it on just a little bit, somebody bumps it, turns it off, and then the person needing oxygen, that's probably a bad thing. So you turn it all the way on. The reason you do a half turn back is because anything under pressure could start to seal itself off. So if this thing's turned all the way on and stays that way under theory, which I've never seen done before, I've never seen it happen, but I've been told this, so I'll go with it, that it could build up to the point that it's hard to turn it back off. Any of you that have done any firefighting operations or done plug work, it's the same thing on a fire hydrant. You turn it all the way on, then a half turn off, right? It's the same purpose, it's the same reason. So for those of you that are on fire department, you will see that, and those of you that are wanting to get on it, the Ontarius, you will soon see that. So, any questions on that? Then you're gonna check right here on your pressure gauge, see how much you have. And this over here is your liters per minute, right? So you're gonna crank that to where you want it to be. Any questions on that part? Good. Also, quick note, when we are working with oxygen, which it should be in bags, we're gonna use bags. Please don't take them out and set them on the table like this. Why?
Knock it over.
Whew, oh my God. Man, I'm serious, don't do it. Don't do it. As soon as somebody takes it out, the next few seconds, you're gonna hear clank, 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 somebody gonna knock it off, so don't do it. All right, I just put it up here obviously for demonstration purposes. We'll set it right here, actually between my legs. So once you decide that you need to put somebody on oxygen, you got your thing set up, we're gonna start with nasal cannula. What is your range of oxygen on nasal cannula?
2 to 6.
Okay, so most books do say 2 to 6, but you're not wrong at 1 to 6. It's that 0 to 6 mark is where you're gonna go. It's usually gonna be at least a 2 up to a 6. When should you turn the oxygen on to this, before or after you put it on the patient? Before, right? So you don't want to stick it up in their nose and crank it on. Plus inevitably somebody's going to put it up to like a 15 to start with, and then you're just blowing snot everywhere. All right, so with the nasal cannula, usually most of these come with a little bit of a cheat sheet on it. There's a little bit of a lip on one side. This one does not have it, but most of them do have a lip. It's a little cheat sheet to let you know which side goes towards the lip. Lip to the lip. This one doesn't have it, so then you just have to follow the curvature, right? So you're gonna look for the curvature of the prongs to know what direction to go in. You put this on, your little oxygen tree, you turn it up to what volume you want. This is a trick of the trade. I know most of you have probably used this quite a bit back in the day in basic, but now maybe you've never been shown this. I take this all the way open, so you got a lot of room to work. Stretch it like this so I have complete control. I'm big on points of contact. Points of contact matter. When I come up to the patient, if I'm behind them especially, I've already made sure that the prongs are in the right direction. Notice how I'm keeping tension here to control it. And then I put my fingers just on the side of the face a little bit while I insert into the nostrils. The reason why I'm doing that is so I have complete control of this. Too many times I was doing this. It was in their eyes. I'm like, I'm sorry, sir. I apologize. This is not my first time. And then it's in their mouth, and I'm apologizing. And I look like one of those people on an infomercial that don't know how to open up a can of tomatoes, and they're knocking the tomatoes everywhere. So it's like, wow, that was real.
Or like the guy with the ladder.
The guy with the ladder is, how do you work this ladder? So, all right, so what you have to do is control it. So by control, I just tighten it, slide it in, and then look, I never take the tension off. I wrap it around, and even with this mannequin with little bitty old baby ears that stuck to the side of the head, I can control that to the point to where it shouldn't pop out, but it did anyways. And now I can just simply cinch it down in the front. And of course that popped off, but it does work better on a human. So once you have that on the patient, you've got the oxygen going, you're ready to rock and roll. What is this going to deliver? What's the oxygen percentage? What to what?
22 to 44.
Bam! Somebody done been reading up in here. Yes, 22 to 44, right? When should you consider using this?
Oxygen saturation usually between 89 and 94.
Okay, so if they dip below 94, you should consider oxygen, supplemental oxygen at that point, right? And then of course, depending on how much they're having trouble breathing, and it could be, they could still be sat at 92, but if they're breathing harder, you may have to go to what? Non-rebreathers. So always titrate to effect adjustments. So let's say you want to go to that now. So you're going to take your nasal cannula off. Going to go to your non-rebreather, which was sitting here yesterday, but it's not here now. Cool. All right, so non-rebreather, what are you going to set your liters per minute at? In the book, and I agree with you, 12 to 15 is ideal. In the book, it does have 10 to 15 as the range. Just, I'm giving y'all the book stuff, so if you see it, you know it's there. 10 to 15 is the range in the book. I recommend 12 to 15, but that is a recommendation. The book says 10 to 15. So you put that on, you turn it to your desired liters per minute, then you got to put your finger over that little thing in the inside, right? And you blow this bag up. So it blows up. Once you have that filled up, again, control. So when you go in, I like to go ahead and widen this out. So you're not doing this on them and it's going all across their head. I'll go ahead and I widen it out. Then I approach from the front, placing it across the face. So you're keeping a lot of that messiness that happens. And I just simply wrap that to the back of the head. Once it's back there, controlling this so it's not sliding all over the place, then you can just simply take and tighten this up. And I see there already that this thing it got looped on me. That could happen, ain't a big deal. I always wanted to do a demo like that guy from Flex Seal. That's a lot of damage. All right, now you just come back and you seal it down. And honestly, things like that's going to happen too. You're going to have something that's not going to look right. Don't leave it, fix it. Then you can pinch down the little metal piece, make sure it fits nice and snug and you're ready to rock. How much oxygen does this deliver?
Up to 90%, I think.
I believe it's up to 95. Up to 95%. If I mention something that seems obscure, know that I'm saying it because I've seen it. All right, so if somebody starts to have more and more trouble breathing, and you need to take him off of this or her off of this, what do you go to?
VVM.
BVM. In the process of getting out your BVM, this thing's inflated. Don't do this. If you're squeezing this, you're not ventilating the patient. You just look silly. I walked up, I'm like, what are you doing? They need to be bagged. I'm like, that's not a bag. That's not BVM. That's a non-rebreather. You are literally doing nothing. So take this off and use a BVM. Right now, Don Terry's like, are you serious? Yes. Clark is serious. I've seen it, so don't do it. Just in case you were ever thinking that way. It's like, well, that's already inflated, man. I don't know why. No, don't. Okay. So you take it off of that. I'm going to lay this down now. And you're going to go to the BVM. Going straight on into ventilation, OPA, MPA, and suctioning. Set that right there. So let's say this person has now progressed to the point that you feel like you've got to start helping them, assisting them with breathing. They've kind of went unconscious on you. So now you are thinking to yourself, okay, maybe I can go ahead and use an OPA. Why are we using OPA for?
Hold the tongue out of the way.
So basically you're preventing, hopefully preventing an occlusion of the airway by the tongue. So you take this and how do you measure? Earlobe to the corner of the mouth at the angle of the jaw, right? So you're going to measure that. Now this is where it gets a little different for some of you, because I know how it was taught. It used to be taught to rotate, then it was taught to going from the side. Now it's only taught this way. Tongue depressor, straight in. That's it. Tongue depressor, straight in. So you use the tongue depressor, take the OPA, push it straight in just like that. And it should fit straight to the base of the lips, just in front of the teeth. That should fit fine. Now, what happens if they start to gag and puke?
Pull it out, turn them on the side, suction.
You're going to take it out and pull it on the side. Look, if this is only if there's no trauma concerns, because if there's trauma concerns, how are you going to turn them?
Log roll.
Log roll with C-spine held, right? So somebody's going to be holding C-spine, you're going to have to roll them like this. But if the person has no considerations of trauma, you can turn the head, not like Chuck Norris, Ron. Not like, don't do that. But I do recommend doing this. You're going to take your hand and you're going to guard slightly against the eruption hitting you. That's important. So I always would come down here, pull this straight out. The reason why my hand is here is to deflect vomit, and then gently turn the head to the side so it can drain while you get your suction stuff ready. You should have your suction stuff ready before you started the OPA, because that is a very likely situation. But if you didn't, now you're going to come over here and get your suction stuff. What does your suction canister have to be able to go up to on your milligrams of mercury, milliliters of mercury, right?
For an adult,
For an adult, 300.
child, 150.
Child's 150. How you check that would be this. So you connect your tubing, you turn your machine on, and then you crimp your hose. Crimp your hose, make sure it goes up to 300 if it's an adult, 150 for a child. Yes, I thought you had a question. What is this kind of suction? Yonker, also known as a rigid tip. Soft suction is the French. All right, rigid tip. How do you make this work?
A little hole.
That hole. If you stick it down in there and you suction like this, then you ain't getting nothing. You got to do that to start the suction. When do you suction?
After you insert it into the mouth.
Only on the way out. Exactly. How long can you suction for an adult?
10 to 15.
No longer than 15. No longer than 15. No longer than 10 on a child. No longer than what on a neonate? No longer than 5 on a neonate. Only suction on the way out. Now, some of these have a little scoop on there. Why do you think they would have a scoop?
Helps.
Because not everything's liquid, right, that comes up. So sometimes you got to remove chunks. So how far do you insert the suction catheter?
Measure.
You can measure from the earlobe to the corner of the mouth. That could give you an indicator. Or what?
No further than you see.
No further than you can see it. That's it. So I would come over here and I would say, that's the sound effects. And then once I feel like, all right, that's good, set that down. I'm gonna replace my man's head to an inline position. Now what am I gonna need to use? NPA, right? So apply the NPA. What are the two indicators to not use an NPA?
Facial trauma.
Facial and head trauma. Facial and head trauma, right? How do you measure this? To the nose, right? From the earlobe to the tip of the nose. Now, you see how that's done? You notice what I'm doing? You see what I'm doing, Ron? Just letting it ride. So I'm just letting it sit there. I'm not doing this. So yesterday, or the day before, I saw this. So it was like, hang on, it's not really reaching. No, that doesn't count. So it's got to make it on its own. So you're just going to put it on the tip to the earlobe, boom. That's going to fit fine. Now, how do you insert this?
Bevel towards
Oh, you've been so quiet, Tyler. Are you okay? Breathing your own CO2 makes you sleepy. Okay, if you start to fall asleep, we'll catch you. Dontarius, be ready. All right, so how do you insert it?
bevel towards the septum.
Where's the septum?
Center of your nose.
Center of your nose, right? Center of your nose. So that's the bevel. You know what? I made this mistake. I assumed everybody knew what a bevel was a few semesters back. We're doing it, we're doing it, we're doing it. Student, I look over, he's doing it wrong. It's like, what are you doing, man? I was putting it in. I was keeping the bevel to the septum. I was like, do you know what the bevel is? He's like, no. Okay. All right. So that's the bevel. It's the flat side, right? So I don't want to assume anything. So it goes towards the septum. I always start on the right side. Why is that? What do you think that is, Jonathan?
The larger nose open.
Because it's a natural curvature, right? So it's the right side, just go straight in, just like that, right? So that usually makes a lot of sense to start on the right side. Before you use this, you're supposed to get out a 2x2 or 4x4, sterile 2x2 or 4x4. You're going to put lubrication in it. You're not going to use alcohol gel. That would not be the right type of lubrication, but for this case it is. What kind of lubrication are you going to use?
KY jelly.
KY, usually water soluble, something that's not going to burn the sinuses. Right, and what do you want to be careful of when you put the lubricant on? To not get it over the hole, right? So you're going to keep it down here, right? So then you're going to take, slide it straight in. And I'm telling you, if you don't lubricate these things on these rubber heads, it is not going to work. Hopefully it goes all the way in just like that, now you're good to go. What about if you catch a snag and it ain't going?
Don't force it. Pull it out.
Pull it out, then what are you going to do? Other side. How are you going to keep the bevel towards the septum though?
Yeah, rotate.
You got to rotate it. Man, you guys know some answers. So you rotate it. Now, this is the time when you rotate it before you stick it in. You know what I was seeing folks do? They would start it in and then they would rotate it up. That's the opposite. So you start it upside down, right? Bevel to the septum. And how far do you go? Till you feel resistance. And then you rotate 180 and complete it. Bam! Now you're in there. Now at this point, hopefully this is doing its job and it's keeping an open airway. Let me ask you this. Let's say this patient starts to wake up. For whatever reason, now you've ventilated, they've come awake. Do you have to take the NPA out?
No.
No. I'm going to tell you, that happened with me many times with patients. You put an NPA in, they start to wake up. Unless they are gagging or having a problem from it, you can leave it in place, because what if that patient goes back out? Now you're having to reinsert, you're wasting more time. Just leave it in place if they're not having problems with it, okay? So you have that in place. Now you want to do this thing called ventilation. You get your BVM out. It usually comes collapsed like this. O2 tubing. Sound like a duck. I got gel on my fingers. And this is about how it looks on the scene. People fighting with it. You put your piece on the end there, and then of course you're going to connect to your oxygen back here. What do you put the oxygen on for liters per minute? No less than 15. No less. You should put it at 15. Put it at 15 liters. This bag will fill up. You put your mouthpiece on. Now, I know every one of you have been through BVM stuff, but you haven't been through my BVM stuff. I have a few things I'd like to talk about because I want to make sure I impress upon you the need for a good seal. What is this part called right here of the mask? It's the part this part's called this for everything that has this type of shape. That is the apex, right? An apex, you have an apex on your heart where a point comes up. If you turn it upside down, what does it make as far as a letter goes? A V. I'm going down the road, Nathan. Stay with me. This will be fun. It's got a V. Now, your nose is made out of what? Carl, you see how spongy that is? That's real world. It could be spongy like that. But does your nose have a bone? It does, up here at the very top. Who can tell me what the name of that bone is? Whew, Jonathan. Is it in there? Nope. What we got? Donovan? He's looking. It's on the left side right now. Go behind that cabinet. Nope, it's not in there. Tyler, you've been so quiet. Thought you were saving it for this moment. Okay, it's the vomer. See how that goes together? V, vomer. Now you're going to take your thumb on that apex where the V starts, and you're going to go to this V. That's the vomer. And you're going to put your pressure here first. The reason why this is important is because you're going to keep it from slipping down, and you're going to create the top seal first. These 3 fingers go on the mandible. Okay, that's your jawbone. What's this little soft area in here? It's the goozle. I just use the goozle. Because if you push in here, what happens? You're going to push the tongue back. So you want to stay on the bone. So if somebody's got big fingers, they could end up way across here choking a person. That's not the goal. You want to make sure you create a good pressure point on the V, these 3 fingers on the mandible, and do you see what I'm doing with the mannequin head? I'm pulling the jaw to the mask, and then I'm pressing down with the index finger. I'm not pressing the mask to the face. You're going to see this in the field. What am I doing if I do this? 1, I'm crushing the nose. 2, I'm pressing the neck back. I'm causing more obstruction than I'm creating patent airway. The goal is patent airway. How many of you guys have seen this, even if it's just in practice? And they're bagging like that. Well, if they're bagging like that to try to get air in, then they don't have a good seal, they don't have a good patent airway. This is all it takes to be able to ventilate. That's all it takes. You don't have to press super hard. You should be able to ventilate perfectly with just this much pressure. If you're doing this, where do you think the air's going?
Stomach.
In the stomach. Have any of you ever seen a distended stomach?
Yes.
It comes way out like this. Look, seeing is believing, right? I did some cadaver labs back in the day. We had a cadaver that had the whole chest, stomach, everything open. We ventilated. They showed just a little bit of force, how much air started going into the stomach. When the stomach expands out to here, and it can do that, it's very elastic. What is happening to everything else around it? It's getting squished. It's getting squished. So you're really putting problems on top of problems. This caused the lungs with a good seal to fully inflate and then come back down. It was amazing. I used to have the video on my phone. I don't know what happened to it. Anyways, doesn't take a lot of work. So you get your good seal. Every time you guys do this, use good technique. Don't get lazy. What did we just talk about earlier? You're going to play how you practice. So practice how you're going to play. Get yourself in a good position. Pull the jaw up. Get a good seal. And then ventilate. How often do you ventilate for an adult?
5 to 6 seconds.
1 breath every 5 to 6 seconds. Bingo. What about for a kid?
Every 5 seconds.
3 to 5 seconds.
Every 3 to 5 seconds. Very good. So when you're doing this, count. When you ventilate, after you ventilate, 1, let's see. You can use whatever state, I don't care. I wouldn't use Texas. But, 1, just count to 5 and then ventilate again. Any questions on that? That's your BVM. That's your OPA. That's your MPA. That's your suctioning. Last thing. I made the mistake, last thing of this part. I made this mistake some years ago. I did not fully cover pocket mask. You know why? Because in my mind, this is like the most basic of basic skills. You learn this from, you have to get your CPR card before you can do anything else in EMS. So one of my first semesters, I was just like, well, they know how a pocket mask is. Well, guess what they make you do in National Registry? You have to use a pocket mask to ventilate because you are responding as a person that is not at work. Man, I had so many students that have forgotten about pocket mask. So I want to refresh you on it. I want you guys to look at it, practice with it, because at CPR station, this is what they want you to use. So you take your pocket mask out, you pop it out like this, and unfold it. You have your strap, place it over the head, tighten it up, and you're going to ventilate. When you go to ventilate, if you're a 2-person rescuer, and you're at the head, which is where you should be if there's another person doing compressions, remember, it's two thumbs here, and you're pulling the seal up from both sides. And you're going to blow in from here. How long of a breath do you give?
About 1 second.
Over 1 second. How many breaths do you give on each cycle?
2.
2. So it's a and then a and then back to compressions. What is the compression to ventilation ratio?
30 to 2 on the ball.
30 to 2. What about if you got 2 rescuers? Still 30 to 2.
For 2 minutes.
Yes, ma'am. Yeah. Do you have to do anything special, or can you just keep taping?
It's still taping.
Okay, cool. So 30 to 2, even if you have 2 rescuer with adults, on a child it goes 15 to 2 with 2 rescuer. So keeping all those numbers in mind, because those are the things that are going to be on test. All right, so when you're ventilating, somebody comes over with some oxygen, this little thing here pops off. You can put oxygen tubing on here. Now you got 100% oxygen flowing into here. I'll put on 15 liters, and you can ventilate. Any questions on the pocket mask? Just know that this is what they will expect you to use. Obviously, you're not going to put your mouth on it in the station, but they're going to have that there, and they're going to need you to demonstrate how you would put it on the patient and how your process would be. Now, if you're from the side, because if you're doing a compressions and you're ventilating, you're going to do the compressions, and then you're going to have to breathe from the side. It's not going to be as good of a seal, because it is what it is. You're by yourself. But when you have 2 rescuers, you're supposed to go to the head and then create a 2-hand seal. Cool. What time is it? Let me see.
11 o'clock.
It's 11 o'clock. We're doing good. Man, I amaze myself all the time. I can't believe it. All right. Let's talk about pulse ox real quick. We're going to discuss pulse ox. You guys will be using a pulse ox in our scenarios and stuff. And I know everyone in here has used pulse ox at some point, even if it was in school. All right, so what does a pulse ox do?
Measures oxygen saturation and heart rate.
Exactly. So do you treat solely off of what the pulse ox is giving you?
No.
No. Always look at your patient. If your patient, and this just, look, I'm telling you, this, I don't make this stuff up. I have to be careful, Ron, because I find myself, if I tell stories and then anybody catches any embellishment at all, they won't believe anything I say, because a lot of things I say, I'm like, I can't even believe that. But it's true. It's true. This happened yesterday. Had a student call me, which happens regularly once y'all get out to the field. They'll call and ask me about a call that they've made. They'll go over stuff.
Tell some stories or something.
And they were concerned that they didn't treat appropriately off of the oxygen saturation, because the oxygen saturation was reading 98. But the patient was gasping for air. And I said, yeah, what did you do for them? So they put them on oxygen, but they didn't start ventilations. And I said, if the patient's having that much trouble, don't even pay attention to the diagnostic tool. The diagnostic tool is there to help you determine how severe something could be. But at the end of the day, pay attention to the patient. You got to treat what you see in front of you. I can't tell you how many times I've had a patient in front of me where vital signs looked one way and they look completely different. I say, okay, on the vital signs, and I start taking care of the patient. So you have to be able to discern between that. What can cause a false oxygen saturation to be? You know, if it's high, what could give you a false high? Carbon monoxide. What could give you a false low?
Cold hands.
Cold hands, exactly.
Yeah.
Fingernail polish, exactly. So that's my point. There are other factors that play in that could cause a problem. Don't fall into that where you just get fixated on what it's giving you. And never, and I say this forever, I don't care how far, I don't care if you become doctor, paramedic, never use the heart rate on the pulse ox as your sole determination of heart rate. It's okay to use that after you've palpated a heart rate. Palpate a heart rate. Now, when you guys get to be a paramedic and you put them on a monitor, and you can feel a pulse and you can see on the monitor, sometimes that does coincide, that's fine. But especially until you guys even get to the paramedic level, palpate a pulse, count that pulse. Then you can reference that off the O2 sat, but never use that as your first and only heart rate. I hope did I drive that point home, Ron? When should you use it as the sole heart rate? When should you use it? Never. Never was the answer. So good. Never is the answer.